Now, this arrangement can be influenced by the parasympathetic and the sympathetic system, the autonomic nervous system. I have no control over my heart rate or the blood pressure. And the parasympathetic system, the nerves come through the vagus nerve to the SA node. There is another pacemaker which is a reserve at the top of the intraventricular septum called the atrioventricular node, which doesn't function normally unless there is a heart block due to the fibrosis of the bundle of His, which can happen with condition like systemic lupus erythematosus. AV node doesn't function, SA node is the one which functions, and the parasympathetic fibers, if you stimulate, it slows the heart rate, and the sympathetic innervates the heart directly, and it can increase the heart rate. The vagus nerve supplies the vocal cord, the orbits. So in a mother who has supraventricular tachycardia, if she has a lot of palpitations and rapid heart rate and feel faintish, we ask her to sit and breathe into a bag or apply pressure on the orbits, and the heart rate will come down. And similarly, in the olden days when they had thyroidectomy operations done, when they passed the endotracheal tube through the vocal cord, the patients died on the table. They thought it was due to a shock of going into the theatre, but essentially what was happening was they were passing the endotracheal tube and irritating in the vocal cord, and they had a cardiac arrest. So they used to take the patient one day, the next day, third day they cut. That was called the stealing of the thyroid. Later they found out the problem of the vagus. They used atropine as a pre-medication to increase the heart rate, so that if you stimulate the vocal cord, it won't come down so much. So the vagus nerve is quite important, and the sympathetic nerve fibers increases the heart rate rapidly. Like if I am here and somebody walks through a door and points a gun at me, my heart rate will I'll try to run. Palpitations, I'll try to run. That's called the fight and flight mechanism. And the chap says the toy gun, my heart rate will come down.
Sympathetic and
parasympathetic is always having an interplay of how the heart rate is moderated.
Very rarely you
might hear an ectopic beat. So if you hear tap, 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 then occasionally tap. That means there is an ectopic foci on the atrium. And the ectopic foci usually is vulnerable to stimulus in an estrogenic environment when the mother is pregnant. So the ectopic beats disappear after the baby is delivered. The ectopic beats don't appear at all. So it's a benign problem, but it can come later on in life if there is stress. Like Tony Blair in Britain, when he was Prime Minister, he used to have ectopic beats. The heartbeats are not sufficient, so he used to faint on the cabinet table during the wartime. And they found ectopic beats, and they had to pass a wire and burn the ectopic sites with a laser. So ectopic beats, we don't have to really bother the mother, because it is likely to disappear and will never come up unless there is a major crisis. On the other hand, if there is a missed beat, so regularly coming, if like tap, 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 and a missed beat, every fourth beat is a missing beat, then it could be what we call as a Wolff-Parkinson syndrome or a pink syndrome. So regular missed beats, you have to inform the pediatrician to check the baby's ECG, but ectopic beats, you don't have to worry too much. So that's about the regulation of the heart rate, SA node, AV node, and the parasympathetic and the sympathetic fibers. Now, in addition to that, the heart rate is controlled by the baroreceptors, which measures the pressure with which the blood is taken to the brain. If the pressure becomes too much, the heart rate comes down. That's due to the cerebral autoregulation. And if the blood pressure drops, not enough blood goes, the heart rate goes faster because of the baroreceptor mechanism. Like if I cut my radial artery and I'm bleeding, my heart rate goes fast because not enough blood goes, so it tries to take more number of times to the brain. Similarly, chemoreceptors, again in the carotid body and the aorta, and if there's a slight rise in carbon dioxide or drop in oxygen, it will rapidly fire, and the heart rate will go up. And when the heart rate is going going up and up and up. Partly is due to catecholamine surge, partly it's due to the drive of the chemoreceptors. When we look at the CTG trace, we will fall back onto these explanations. So the heart rate is controlled. Initiated by the SA node, modulated by the sympathetic and parasympathetic, and to some influence by the chemo and baroreceptor.
This diagram tells
what we have already discussed, sympathetic, parasympathetic, and chemo and baroreceptors. But the most important one is the adrenal gland.
I know in India, for example,
majority of cases might be monitored by intermittent auscultation. Now the principle behind intermittent auscultation depends on the function of the adrenal gland. Adrenal gland is a stress gland. The catecholamines come immediately. The adrenaline, noradrenaline causes tachycardia, increase the heart rate. So whenever there is a constriction, so whenever there is hypoxia to the tissue, there is a catecholamine trigger.
If I cut, there is a
catecholamine trigger, but subsequently the cortical hormones comes to reduce the inflammatory product.
The auscultation process depends on how
the adrenal medulla is going to secrete the catecholamine with hypoxic stress. Gradually it will go up, so when we auscultate, if it goes from 130, 140, 150, 160, that means there is a rise in the catecholamine.
So let us see that
in a graphical form.
Not the
original, but a copy of Calderabasia's work. Calderabasias was a perinatal physiologist from Montevideo who was looking at positions in labor. And he was asking midwives to listen when the mother was delivering from a small stool, big stool, and so on. Initially, he was interested by putting a phonocardiogram, because nowadays the machines use ultrasound transducers. Those days they didn't have ultrasound, so they used a phonocardiogram to pick up the actual heart sound. When he asked them to count for 15 seconds and multiply by 4, they made mistakes because you multiply the error by 4. So then he gradually moved it to become
1 minute,
auscultate for 1 minute, which is almost similar to what he found on the phonocardiogram. Now that was used by randomized controlled trials in Dublin, comparing electronic fetal monitoring with 15 minutes auscultation, and found to be good. That is why it has come into practice, that every 15 minutes we listen for 1 minute soon after a contraction in the first stage, and every 5 minutes in the second stage. The second important information from Calderabasias was this.
He wanted the midwives to deliver
at the time of a contraction, because he thought that's the time of maximal stress. But the midwife said, we can't listen because when you apply the stethoscope, it's painful, and secondly, the sounds are muffled. So he was a bit puzzled how best to resolve the solution. So he did a very simple solution. He took the graph and draw a line from the beginning of the contraction and the end of the contraction. And if the deceleration fell within these two lines, generally the babies came out in good shape. They didn't have any problem. Because when it falls within these two lines, the duration at the normal baseline is much longer compared to the time the deceleration takes place. If the baby is going to get worse due to hypoxia, the decelerations get deeper and more prolonged. So if I draw a line here and draw another line at the end of it, that line will fall outside that second line. So that is what we call atypical variable. In a variable, the deceleration should start at the beginning of the contraction, whereas in the late, it starts 26 later.
Now what you have to observe here
when the baby gets hypoxic, that means the coronary filling of the baby is also reduced. So the deceleration can deeper and wider with progress of time. The catecholamine surge increases the heart rate, so it can go from 140, 150, 160. And the interval between the decelerations gets shorter and shorter. So it's like immersing somebody underwater for 60 seconds initially, then for 2 minutes, then for 2.5 minutes, then for 3 minutes, and keeping the person on the surface of the water only for 3 minutes here, 2.5 minutes there, 2 minutes there.
Gradually the baby deteriorates.
Gradually the baby deteriorates.
The
rising baseline rate,
increase in depth and
the increase in depth and duration of the deceleration and finally it affects the autonomic nervous system, and the baseline variability gets reduced. Once the baseline variability gets reduced, that means the autonomic nervous system is affected. So what we had to really recognize when we are interpreting the CTG is to take the first 20 minutes of the CTG as the baseline. So if you want to compare this trace at 11:30, you don't compare with what happened at 11:20, but if she came in labor at 9 o'clock, that's the trace you are going to compare. So you will say at 9 o'clock she had 130 heart rate, at 11:30 she has a heart rate of 160. So you know the difference, how much it has gone through. Secondly, you know the duration of deceleration was 1.5 minutes. Now it's 2.5 minutes. And the interval between the deceleration was 4 minutes or 3 minutes here, and gradually it is going down. So that is quite important. As medical people, we all know, if you are monitoring a patient of pre-eclampsia, you will do the liver function test and the renal function test. And you will say, last Monday, the creatinine, urea, alkaline phosphatase, everything was this. The next 3 days later, this was the level. 3 days later, this was the level. So you are comparing how things going on. You don't make a decision based on one particular reading. When it comes to CTG, for some reason, we are just looking at that window as a snapshot, and we are trying to take the reading instead of saying this has become from 130 to 160. The interval between the deceleration is getting shorter. And the moment the deceleration interval gets shorter compared to the time at which the baby's at the baseline, hypoxia starts coming. Or if the baseline